So before we start talking about how to manage addictions after bariatric surgery, we're going to actually need to spend a little bit of time on some background information, and we probably should back all the way up and ask, do these kinds of problems even occur after bariatric surgery? And to answer this question, we can kind of break the addiction category down into three different kinds of problems, the first one being problems with drugs after surgery. And there's very, very little research out there on this topic, but what little research there is suggests that this is pretty rare. And then we can consider what are called behavioral addictions, meaning problems with compulsive behaviors like these. All of them sound kind of fun, but if you do them too much, it's a problem. And again, we have very little prevalence data on these, but the research that is out there suggests that these kinds of problems are even more rare. What we know quite a lot more about is the prevalence of alcohol problems after surgery. And we know that post-operative problems with alcohol are the most common by far. This is definitely a thing. It's happening. But of course, we need to know a lot more about these kinds of problems than simply what the prevalence is. Why does it happen? Who does it happen to? When does it happen? So looking at how much we know in general about each of these kinds of problems, breaking it down again by those three categories, I can tell you that what we know about problems with drugs after surgery is almost nothing. And for those behavioral addictions, we know even less. Now, with post-operative alcohol problems, we actually do know quite a bit, although we are missing a lot of basic information about many aspects of this problem, but we do know more about this. So what I'm going to do now for the next few minutes is briefly review some of what is known about post-operative alcohol problems in specific. And first of all, we can look at whether different bariatric procedures confer the same level of risk of post-operative alcohol problems. And we do know that with the band, really doesn't seem to be much of an issue. Bypass, on the other hand, seems to be a clear risk factor for alcohol problems. And in fact, the prevalence of alcohol problems in post-bypass patients is about 10%. There's pretty consistent findings on this prevalence. Now, we need to consider the sleeve, right? Because this is now becoming, or possibly has become, the most frequently performed bariatric procedure worldwide in the last few years. Unfortunately, almost no prevalence or other research has been done with using sleeve patients. So we really don't know about sleeve patients. But if we go back and we take a look at the 10% of bypass patients who report alcohol problems after surgery, within that group, we see three different phenotypes. And one thing that people often wonder about is whether bariatric surgery or the bypass in specific pose a risk of relapse among people who have previous alcohol problems but have achieved abstinence and sustained recovery. And the research, I think rather reassuringly, suggests that this doesn't seem to be much of an issue for those folks. And then, of course, we want to know whether some of those 10% of people who are reporting alcohol problems after bypass, maybe they had alcohol problems at the time of surgery, and that was something they sort of forgot to tell us about in their preoperative assessment. And the answer here is more complicated. We do know that heavy alcohol use or having alcohol problems at the time of surgery is one of the risk factors for having these kinds of problems after surgery, but it's also been found that some people with those kinds of problems actually report an improvement or a remission of their alcohol problems or a significant decrease in their alcohol intake after the bypass. So here we really could go either way. And then, of course, there's that most interesting group, which is the subgroup of people who have no lifetime history of alcohol problems at any point before the bypass, but then they develop them afterward. And we know that among patients with no preoperative history of alcohol problems, after the bypass, about 7 to 8% of them develop alcohol problems. And in fact, of those 10% of all bypass patients who do report alcohol problems after surgery, about 2/3 of those cases are new onset cases, which is a rather startling and concerning statistic. And of course, there's lots of other information that we want to know about these problems as well. For instance, at what point in the post-op course do these problems arise? And I think most of you probably know that there does tend to be a delay. We don't tend to see these kinds of problems very often within the first post-op year, and the risk seems to increase significantly around the second post-op year. But what's very worrying is that there's data emerging that this risk continues to climb through at least 10 years after surgery. You know, risk of things like DVTs, stuff like that, we think of the first 30 days as being the highest risk time, after which you feel a little safer. With alcohol, it's the other way around. The longer it's been since surgery, the higher your risk. And this is a graph from the SOS study from a 2013 paper. That line on the top is the bypass patients. And you can see the incidence climbing year over year. Yesterday in this same hall, they presented their 20-year chart, same chart, showing that this risk is continuing to climb up to 20 years. And I know there's a small percentage of bypass patients in that sample, but the labs people have just published their 7-year data showing the same thing, that the incidence is increasing over the 7-year course of their study period. So after looking at all of this information, usually the next thing that people want to know is, why does this happen? And here I'm going to go back to talking about all kinds of postoperative addiction problems, not just specifically alcohol. And one model that's very, very popular in the lay public and among some of our colleagues as well is this idea of addiction transfer, sometimes also called transfer addiction. So this is the idea that these were patients who before surgery were, I'm going to use air quotes, they were addicted to food. Now they've transferred that addiction to compulsive behaviors or substances of abuse. That sounds really reasonable, but there's some number of different lines of scientific findings that strongly argue against this, which if there's time during questions and answers, I'm happy to be more specific about that. Now, another possibility is that these problems happen because at some point after surgery, the patient is encountering a significant life stressor. Perhaps they have inadequate coping skills, and so they're using alcohol or drugs or some kind of compulsive behavior to deal with their stress and their other negative emotions. That also sounds very reasonable, but nobody's tested that out, so we don't know. Now, if we go in a different direction and we look at a possible physiological explanation, it's quite natural to assume that that might be involved in what's going on here because, of course, we know that bariatric surgery alters the GI tract, so that would affect the use of and the impact of substances that are ingested. But what about non-ingested drugs or those behavioral addictions? Well, another line of research that's starting to emerge is that along with affecting the GI tract, some bariatric surgeries also seem to be causing changes in brain reward pathways. So together, it seems likely that the combination of both of those kinds of physiological changes is playing a role here. All right, so now that we've got some important background information about postoperative addictions, let's answer the question that this title is suggesting, which is, what do we do about these problems? And I'm going to start off by talking about what we do in the arena of treatment. Now, unfortunately, there's literally no research that's ever been done looking at treatment for postoperative addiction problems. And also, specifically, nobody has examined whether a specialized addiction treatment approach is required for bariatric patients with addictions. Now, up until about 14 years ago, when I went full-time into bariatrics, I actually specialized in addictions and substance abuse. And based on my knowledge of that domain, I personally don't feel that there is any particular reason to suspect that bariatric patients with addictions would not respond to the existing approaches that we already have found to be effective for treating addictions. So things like a cognitive behavioral approach, 12-step approaches, or even pharmacological approaches like naltrexone, acamprosate, topiramate, some of which drugs also have beneficial effects on weight. and eating. So this might be a way to go for them. So you don't need to seek out specialty bariatric addictions treatment services, which is good news because those really don't exist. But I would definitely advise any bariatric practice, if you have a patient who you suspect is having a kind of addictive issue after surgery, first of all, if you've got a behavioral health member on your team, ask that person to check in with the patient. And also, make sure, and this is something that if you have a behavioral health team member, you can task him or her to do this, and they'll be happy to do so. Please work on developing and maintaining a database that has resources, addictions treatment services, facilities, different addiction specialization professionals to whom you can refer patients who are experiencing these postoperative addictions. Now, obviously, what we'd really probably rather do is to make sure that people don't develop addiction problems after surgery in the first place. So I think it makes a lot more sense to focus on prevention. And one good argument for this, and I think most of you probably find this to be true, is that we tend to see a lot more of our patients while they're seeking surgery and getting ready for surgery than sometimes we do after they've had their surgery. So the first thing that we should be doing is really educating our patients about the risk for addiction after surgery. Sorry about that. And we should be doing this before patients have surgery and then refreshing that education after surgery from time to time. And of course, what goes hand in hand with that is that we need to be monitoring all of our patients after surgery for signs of increased or problematic substance use or addictive behaviors. And it's especially important to remember that that high-risk time for this is at least 2 years, if not many years after surgery. So we really need to be doing some long-term monitoring of our patients. Now, that's resource intensive. So if you need to be sort of figuring how to deploy your resources in the most sort of efficient way, you might want to take a look at investing more of your resources in people who may be most at risk. Now, because this was a short time slot today, I didn't talk about what little information we do have about predictors of these problems, but there are a few factors that have been found to be associated with a higher risk of alcohol problems after surgery, and those may be risk factors for other kinds of addictive behaviors as well. So we know, as I said, the bypass procedure, people who are heavy users of alcohol, problem users of alcohol before surgery, or people who are using recreational drugs before surgery, and also people who themselves don't have a history of addiction, but they have a genetic family history of addictions, are also more at risk. Now, being a psychologist, I'm very, very comfortable with asking people about addictive behaviors and substance use, but some of you may not be as accustomed to doing this, so I've prepared a short list of sample questions that you can use if you want to do some quick screening of patients, post-op patients, to see whether they might be having any of these problems. And we'll start with alcohol. And first off, you'd want to ask about frequency. How often are you using alcohol? And of course, also the volume. How much alcohol do you drink on a typical occasion when you're having alcohol? And one thing you really want to be conscious of here, if it's a bypass patient, remember, I think we all sort of know this, that alcohol patients have highly, highly enhanced absorption of alcohol after surgery. So a bypass patient who's having 2 or 3 drinks on one occasion, that's enough for them to be blacking out and being very, very intoxicated. So if someone says, I have 2 or 3 drinks 2 or 3 times a week, for someone who hasn't had surgery, you might not worry, but for someone who's had a bypass, that kind of volume would be worrisome. And often with these patients, you hear of even higher volumes than in people who have alcohol addictions who haven't had bariatric surgery. So keep that in mind. And you also, once you've talked about the quantity and frequency of the alcohol use, you need to put that into context by finding out whether this is different than what they were doing before surgery. If they're drinking about the same amount, or even if it's a little bit less, but we're kind of correcting for that enhanced absorption than they were before surgery, you might be slightly less concerned than if the quantity or the frequency has increased. That's a definite red flag. Even if someone's gone from being a non-drinker to having drinks once a week, that would be a little bit of a red flag for me. But it's very, very difficult to sort of assess whether, just on the basis of quantity and frequency, whether someone's alcohol use is a problem. And in fact, that's not part of the criteria for diagnosing a substance use disorder. What you should definitely be asking about is whether the patient or anyone close to the patient has expressed any concerns about their alcohol use, and whether the alcohol use has been having any consequences in their life. Is it affecting their work, their relationships, their health, their weight loss? And what function is the alcohol use serving for the patient? If the patient says, well, I'm using it to unwind every day, it's the only thing I can do now to help me with my stress, that would be concerning as well. Now, asking about drugs, you do this pretty similarly. Have you been using any drugs? Also make sure that you're asking whether people are using their prescribed medications differently than they are prescribed to be used. So one thing we know is that prescriptions for opiates increases after surgery. That doesn't mean people are misusing them, but you might want to ask them, are you running out of these medications more quickly and having to get a new prescription more quickly? And if you've been using illicit drugs or misusing prescribed drugs, how often have you been doing this? And is this a new behavior since your surgery? Although I would say both for drug use and also for behavioral addictions, these are things that you'd be worried about either way. Even if it's not a new problem, you might want to refer this person for help. When asking about addictive behaviors, I ask one question in all my post-op visits that covers everything. I say, are there any behaviors that you've been doing too much of lately, like gambling, shopping, sex, shoplifting? And again, is this a new behavior since your surgery? Although, as I said, if it's a problematic behavior, it's a problematic behavior, and you may want to address that either way. Now, before I finish up, I need to go back to a point that I've made a couple times already, which is that risk for postoperative addiction seems to increase over many, many years. And usually, we are only seeing our bariatric patients consistently for the first year or so, and sometimes not even that long. So addictive problems after surgery are likely to be developing long after these patients have stopped coming to our clinics. So one thing I think we really need to be doing is educating all providers who are likely to be seeing our patients years after their surgery. So this is going to include GPs, endocrinologists, definitely behavioral health providers should be aware of this, and substance abuse providers should be aware to be looking out for bariatric surgery history in their patients. Even specialists like orthopedists or cosmetic surgeons or cardiologists, anyone who our patients are going to be seeing 5, 10, 15 years after their surgeries. And I think this is probably the most effective means of prevention and early detection, and it's also, I think, where there's the most room for improvement in our field. It's also something we can start doing right now. We don't need any more research to come in. We don't need any new treatments to be tested. So let's get out there and educate our non-bariatric colleagues and ask them to be keeping an eye on our patients after they've left the nest. Thank you.